Thank you, Atul. Yeah, so I found Halloween a little bit strange initially. That when you go around to people and they start and knock on their door and they give you candy, but it is you come back with a nice haul of candy. Uh, Unfortunately, today, of course, we have been told that Halloween is cancelled. So because of COVID, there is going to be no Halloween. So we are planning to do it inside our house, where my son will go knock on one door and the other door, and we'll pass him some candy. So let's try. Okay. So for the second part of today's session, we'll talk a little bit more in depth on meta-analysis. So everyone knows I'm from Canada, and I forgot to put in pictures of fall last session. So on Atul's demand, I'm putting some pictures. This is how it looked a couple of weeks ago outside. Um, it's actually very beautiful. All the leaves change, especially we have a lot of maple trees. All those trees change color. This year we had a very colorful autumn or fall, where, as you can see, these are real pictures from that time. It all becomes red and yellow, and it becomes really nice. In terms of disclosures, I do have, I do a lot of systematic reviews. Not everyone at Cochrane likes me, especially the Canadian Cochrane people, which is a hypertension group. The Cochrane Kidney and Transplant group is based in Australia, and they get along with me. I'm a reviewer for them. I don't have any financial conflicts of interest. So sometimes when and again, there'll be a little bit of things that we will be talking in common from what you heard from Atul. So sometimes it's okay just to do a qualitative synthesis. When you put all your studies together and you're looking at the data, and if it looks like 4% and 70% zero surveys from two different areas, you should shake your head and say, hey, it's not a good idea to combine them, and it's okay. In fact, sometimes it's okay not even to combine anything and just to present the data separately in what we call as a qualitative or a narrative synthesis, without giving you a quantitative synthesis. And what do I mean by that? So for example, you should always construct tables before you come to the forest plot, and in a table you're looking at stuff like in this case you're looking at study design. You're looking at where the studies were, which countries they came from, what was the inclusion and exclusion criteria, how long was the follow-up, and sometimes this is what you end up with. This is about a decade ago. We did a systematic review of antiplatelet medications in dialysis patients, and we were looking at bleeding rates. So looking at aspirin, dipyramidol, ticlopidin, clopidogrel used in dialysis patients, and how often do they bleed. This is published in CJS. And then when you looked at it in that table, some of them were trials, many of them were prospective cohort studies. So that's one way that these data were quite different. The control group, it sometimes was placebo, and sometimes there was no placebo. It was like standard of care. The dropouts really did vary. The numbers analyzed were often different than the numbers that were included in the trial. And some of the studies were really long, 1028 person years, and some of the studies were 3 months, and some were 6 years. So would it really be fair to include all these studies together in a meta-analysis? And there's more. So some of them were aspirin, some were sulfenpyrazone, some had warfarin combined with the aspirin. So there was a lot of different, the interventions were quite different. More importantly, the definition of the bleeding was quite different. So in some cases it was GI bleeding, in some cases it was transfusion, in some cases it was major bleeding, which is someone got hospitalized with the bleeding. In a couple of papers they didn't even specify how the bleeding was described. It was just bleeding events. So it became very difficult for us when we tried to put all the data together and say that we really could not combine it. We could not do a meta-analysis. So all we did is we just showed the tables and we showed, hey, this is the state of the data, that there is bleeding. It seems to be high with these agents, and these are the kind of rates that you see. So it's okay. You should not consider that doing a meta-analysis is always necessary. Success is not based on meta-analysis. It's just doing a systematic review is sometimes fine. So the quantitative synthesis is, of course, the fun part of it, and that's what we will talk about. But it's okay sometimes not to do it. So we talked a little bit about this last time. Is to, when you're synthesizing the results of multiple studies, these are the things that you should be looking at. So there's a graphical analysis, the forest plot, but there is the summary statistics that you should be looking at. There is measures of heterogeneity and homogeneity that Atul mentioned, and some sensitivity analysis that I'll come to. These analysis is not the only thing. So we will only talk about meta-analysis, but these kind of pooling studies together is used in other study methods as well. For example, if you're doing a decision analysis about what is the best strategy to use using Markov models, or a cost effectiveness analysis, and often policy people use combined studies using alternate analytic methods. And going on to fall, so right now the leaves have all gone. So you can see my son on the right. All these trees, they have leaves, but as you can see in the next picture, the leaves are all gone. They're all on the floor now, and the trees are barren. So right now, this is the state of affairs in Ottawa, and soon it'll all become white. So from roughly November to April, it is just black and white. So I think the colors of the leaves that come before start preparing us for a black and white 6-month world, which we'll be living in for the next little while. Coming to the choice of the metameter, and again, this is partly what we talked about last time. Most commonly, we use a risk ratio or an odds ratio, but sometimes it's okay even to use a risk difference. So, if you've got two studies with, 10%, two arms, you can talk about 10% event rate in the other one and 15% event rate in the other one. So it could be 15 upon 10, which is a risk ratio of 1.5, or 15 minus 10, so a risk difference of 5%. So you can combine on an absolute scale or a relative scale. And sometimes it's trickier, but it could even be done to look at time to event. So survival analysis or Kaplan-Meier kind of analysis. And for continuous measures, so a change in creatinine or a change in proteinuria are the common ones that we face. What is often done is a weighted mean difference. The weighted mean difference, of course, and there are other options like a standardized mean difference, a regression slope, and the other stats I'm mentioning there, but they are harder to interpret. A weighted mean difference gives you a number which looks similar to change in proteinuria or change in creatinine. It will give you a number which can be interpreted the same way. A standardized mean difference has some better statistical properties, but it does become extremely hard for us to conceptually understand what is going on there. So those are some considerations when you're choosing. The software may give you all these options, but you should know what to choose and where to click. And when you compare, that's some statistical gobbledygook for anyone who's interested. But even within fixed effects and even within random effects, there are many other options. The most common option that is used for fixed effects is the inverse variance. That's the standard method used by Hiremath, is the inverse variance method. But there are other options such as the Mendel-Hensel effect. If you have very, very few events, 2 deaths and 4 deaths here, or 1 and 2, then the P2 effect may be slightly better in theory. And then the other option, of course, is random effects, where the most common one is used by Dersimonian and Laird. But there are many other options also for random effects, and I'll show you a few. And again, the Mendel-Hensel is the alternative, and that may also be better when the data are sparse. So conceptually, how do you think about it? So if you have 3 studies like this, the stats makes the assumption that they're all coming from the same sample, and it's just variation in the sample that is causing the point effects to be slightly different. And it will give you a relatively tight 95% confidence interval. The random effects model does not make that assumption. It makes the assumption that all these studies may be coming from different um, samples completely. So it does not weigh the studies the same way as the fixed effects does. And that often results in a very wide 95% confidence interval. And again, in fixed effects, assumption is that the studies are replicates. So if you do the same study in the same population, sometimes you can get like the zero survey. Let's say sometimes you can get 4%, sometimes you may get 7%, sometimes you may get 6%. So you will not get the exact same answer every time, and that's the assumption of fixed effects. And the other assumption is that if you do a large study, you're more likely to be closer to the truth. So if you do a study of 100 patients, you may get some random error. Whereas if you do a study of 1,000 patients, you're more likely to be correct and find there is supposedly a true number. So it will weigh the larger study more, and it will give you it a way more weightage compared to the smaller study. And it does that by the variance. So the variance is inversely related to the sample size. So that's how it gives the weight. Whereas the random effect makes no such assumption, and it is less focused on the large studies. So it makes the assumption that studies are different because of many other factors that are there, and the weight is less focused on large studies. So and we'll see some examples of that. And which one should you use? So even now there are discussions and fights about what was the right way of doing it. So there is no, it's again often the philosophical discussion about which one is the right one to do. Often if there is high amount of heterogeneity, people make the assumption that random effects is the right way to do it, but it's not always right, because it may be that some other study which is large, may indeed be the true value that you're getting. So it's important to explore what is going on rather than just say, oh, I use random effects and I'm done, I'm fine, when you see heterogeneity. And practically, of course, the random effect model is more conservative, and it will give you slightly bigger 95% confidence intervals. But if they give you qualitatively different answers, right, one is saying it's positive and one is saying it's negative, then you are in trouble, and you should really explore rather than say, oh, I like this answer, I will use this method. That's not that's not giving you the complete picture of what is going on. So the forest plot, and Atul showed you one forest plot, and this is not the forest we are of course talking about. It's this forest, and just to dive in a little bit more, this is a systematic review and meta-analysis of oral hydration versus intravenous hydration in preventing contrast nephropathy. And now, as you can see in the individual trees, so these are the trees in the forest. That's what the forest is. It was not the name of a person. It is just a forest, meaning we are putting trees together in a forest. And it's good to step back and look at the forest rather than get bogged down in individual trees. The reds are telling you the point estimate of the individual study, which is the odds ratio in this case. And the lines are telling you the 95% confidence interval of the individual study. So you can see that there is one study, the second one by Trivedi, which showed that intravenous was better. All the other studies are seeming to overlap one. So they seem to show that there is no effect. But let's see what the pooled analysis shows. And the pooled analysis shows is a diamond. It's usually a diamond that is used. It doesn't have to be a diamond. Sometimes it can be a large square. But in this case, the diamond shows that the summary effect is 1.12, 1.19, and the 25%, 95% confidence intervals cross 1. So it seems that there is no difference between oral and IV. And you can look at the individual columns. You can choose the columns that you're showing, of course. In this case, the p-values refer to the individual p-values. And again, they reflect what you're seeing in the graph. So for the second study, the study by Trivedi, the p-value was 0.004 because it was positive. The others, as you can see, the p-values are all greater than 0.09, and the overall p-value is 0.725. And in this corner over here, you usually see the heterogeneity data. So in this case, that's the Cochrane's Q, and the I square. The I square is large. It is 57%. So, as Atul alluded, 30 to 50% is moderate level of heterogeneity, and more than 50 is a high level of heterogeneity. And so in this forest plot, they don't necessarily look like they're overlapping, but they didn't look as different as the graph that Atul showed. But in this case, there is a high level of heterogeneity, and a random effects model, which is what was used here, is quite appropriate to use. And again, this is not an extreme example. It's not like studies are very, very different. But so it was reasonable just to stick to the random effect model. And so the interpretation of this forest plot was that when it comes to the oral or IV route of hydration, there was no significant difference on AKI events. It wasn't really low. It was a moderate to high level of heterogeneity in this meta-analysis. Now, some people are like, oh, and again, a clean analysis is when there is a low level of heterogeneity, and there are small studies which did not show significance, and you pool them, and voila, it is significant. So that is an ideal case, but that is a very easy case, and it rarely happens that you will see that sort of an analysis. That was, of course, the Cochrane logo on steroids in neonatal infant acute respiratory distress syndrome, where they use steroids, where there were a bunch of underpowered small studies done. And when they pooled them, they were all homogeneous. They all showed a similar point estimate benefit, but they all crossed one. And when you pooled them, you saw that there was a benefit. So that's the ideal case scenario. If you get that, you're lucky. But if you get heterogeneity also, don't panic. There is a saying that it is your friend. So there is always some unexplained heterogeneity. And it can use an insight. You can play around with the data, you can do some analysis, and actually you can find something that is interesting. And my professor who taught me meta-analysis used to say, you have to tell the story. There is a story that the data is trying to tell you, and you look at it and you try to find out what is the story and interpret it. And that's way more fun than just clicking and producing a forest plot and moving on with the summary estimate. So again, these kind of analogies, Atul talked about apples and oranges, but a similar analogies when you're faced with these, ponds, and there are ponds of different color, and someone asks you what is the average color. I don't think telling the average color is, whatever is orange or reddish green or something will be helpful at all. It doesn't tell you the true story of what is going on. And if we use the apples and oranges analogy, which is very, very common, there are two schools of thought. So one school of thought is that, you should pool everything together. These are the lumpers. And the lumpers believe that, you want a smoothie. You don't care what kind of fruit is there. Put it all together, put it in a blender and get the summary estimate and present that summary estimate. And on the other hand, there are other people who believe that no, it is not right to pool them at all. What you want to produce is a fruit salad. Do the subgroup analysis or do a qualitative synthesis, and do not produce the just single forest plot. And the splitters want a fruit salad. And philosophically, it does make sense to show a fruit salad rather than the smoothie. But you can have your cake and eat it too. You can show both of them. You can show a forest plot to give an idea about the overall estimate, and then you can show all the details as well for people who want that. And the trick, of course, is here to convince the journal editor to accept what you have done, and for you to get a sense of where the data is going. So this is an example that is often used. So I've had the BCG in India. Everyone gets the BCG. Interestingly enough, in Canada, my kid did not get a BCG. They don't give the BCG here because they think that the incidence is so low that no one should get the BCG. And part of the discussion about does the BCG vaccine work or not? And there are other, I'm not an infectious disease guy, and there are other schools of thought about what BCG does prevent. Maybe it prevents the more serious form of TB, and not all TB. But these are some studies that have been done. These are all randomized controlled trials from 1948 to 1976 on giving BCG and cohort studies and trials on giving BCG and what happens to cases of TB. So A is the number of events in one arm, and B is the number of events in the other arm in the columns. And C and D are the total sample size in these studies. So even offhand, when you go through the column, so it's done over a period of 30 years. And I'm sure in the period of 30 years, there has been some development about how we manage and treat TB, which is important. Secondly, look at the sample sizes. So the third study there, Rosenthal one from 1960, it has a sample size of about 500. And if you scroll down, there is a study called the Madras study that was done in Chennai by WHO, and that has a sample size of about 90,000 in each arm, so about 1,70,000 patients. So that is many times larger than that study by Rosenthal with 500 patients. So should you give equal weightage to those studies? So the Rosenthal study shows that the relative risk is 0.26, whereas the Madras study shows that the relative risk is 1.0. So is it really fair to combine these two studies and say, use the random effects model, and the Madras study gets almost equal weightage as what the Rosenthal does? And that's where, it's not necessarily right to use one method or the other. So even before we do any meta-analysis, you can look at this, and I've not put all the other study characteristics, right? What was the age? What was the gender breakdown in the studies? What else was being done in those countries? What are the countries? And all those factors are really can easily tell you that there is going to be a huge amount of heterogeneity here. And this is the forest plot, right? This is a simple forest plot. And it just easily shows you that there is a huge amount of heterogeneity that is going on. So in the middle there, you see the Madras study, which is squarely on 1, showing no effect. And it's a large square, whereas some of the other really small squares. So the size of the squares tells you the weight of the study involved. And it shows that, those studies are showing that there is a benefit, and overall, there seems to be a benefit. So, but there is a huge amount of heterogeneity here, and you're missing the story. So how do we make sense of what is the story going on here? So heterogeneity is common, and sources of heterogeneity, as Atul has alluded already, it depends on the population studies. It could depend on the nature and level of the exposure and the treatment. It could depend on what are the study methods being used, and the exposure and the outcome measure as well. How did you examine what was TB? Did everyone have an X-ray, or was it only people who came with symptoms? So you're going to pick up more subclinical disease, or you're going to pick up only the people who become really sick? Was there enough loss to follow up? Patients maybe, got TB, but they never came to you. They died at home. If you're not good at capturing all those things. How was the assessment done, and was it a good quality study or a poor quality study? And doesn't mean that a poor quality study would necessarily show a good or bad outcome, but it may just be that there is enough noise that the bias in that study could be towards the null. And often studies, this is the study of meta-analysis, and it shows that often people study for heterogeneity, but rarely is it discussed. They just say there was heterogeneity and we used random effects model and move on. And really that is the wrong approach to this. And if you ever do a meta-analysis, I'd like to convince you that you should be doing more than that, and having fun and play around with the data a little bit. So it's important to measure the sources of heterogeneity before. You look at the table. You are the content expert, so you look at the table and you should be able to say, this study had mostly children and this study had mostly adults, and that's even before doing the meta-analysis. You should say, this is something we should identify and look at closely when we combine the study. This study had mostly men. This study had 50% men and women. Maybe you will see a sex or gender effect there. So those kind of things you should be identifying even beforehand, before you do the stats, and saying, hey, these are potential sources of clinically of heterogeneity, and we should look at that. So again, using a random effects model is one option, but exploring those sources is having fun. And when you write up the paper, it's important to acknowledge whether you could identify the source beforehand, and B, whether how much of the heterogeneity is explained by the factors that you are looking at. So again, what is your story? What is the story you're telling is far more important than just the forest plot. So there are a few ways to explore heterogeneity. One is by doing a subgroup analysis. Of course, the easy option is just to do a random effects and move on. But you can look at these subgroups. For example, if you had some studies were in children and some were in adults, you say, okay, we'll combine the studies that were in children separately, and we'll combine the studies that were in adults separately, and we'll look at what was the heterogeneity in this group versus that group. And if that solves your heterogeneity problem, if it's very clean, then you just say, rather than presenting the overall effect, you say, hey, this was the effect that was seen in children, and this was the effect that was seen in adults, and the heterogeneity was completely solved. On the other hand, you can also use age as a covariate. So you can model age and the effect size in what is called as a meta-regression, and that will tell you whether the effect varies across age. So rather than grouping children and adults separately, you can say, hey, in younger people there seems to be a lesser effect, and in older people there seems to be a greater effect, or vice versa. So that's the using the same covariate as a quantitative measure rather than a qualitative subgroup. So that's something to keep in mind when you're doing these exploration. So let's see some of these explorations. So I've taken the same studies of BCG, and this is one forest plot. And this shows that the overall relative risk is 1.05. So there is no benefit at all with BCG. And this is another forest plot. Again, you can see it's the same data points, but it's pooled in a separate way. And you can look at the diamond at the bottom. It shows that the relative risk is 0.57. So there's a huge benefit, like a 40% relative risk reduction with BCG. So what is the truth? Which one should you present, right? Should you pick the one that is convenient and say, hey, this is it? The one on the top is in fact a fixed effects model, where the large study, the Madras study, gets a huge weightage. And that's why it pulls your confidence intervals towards 1, whereas the one lower down is the random effect. So it's not necessarily true that a fixed effect will show you an effect, whereas a random effect will just have broad confidence intervals. The confidence intervals are broad, but you can see that the point estimate also can vary hugely. And this is an example where they are qualitatively different. It is not that the fixed effect and random effects just overlap, but they give you dramatically different answers. So you have to decide a little bit and think before you use one option or the other. So let's explore this in a little bit more detail. So this is how the weights are. So the blue line shows the weight given by the uh, software to the individual studies for a fixed effect. So as I mentioned, for a fixed effect, it did give a large weightage to the Stein study, which was negative, and the Madras study, which was also negative. So that is what pulled your summary estimate towards 1. Whereas the random effects gave, somewhat equal weightage to all the studies, and that's why they showed, interestingly enough, they showed that there was a huge benefit with BCG. But is that the true answer? Um, so either it has no effect or it has a huge effect. So the heterogeneity was very high. The p-value is less than 0.0001. So you do need to explore the causes in this case. So one option is to do some kind of a meta-regression. So use one or more study level variable that may explain part of the heterogeneity. And as I said, it could either be a continuous variable or it could be a discrete variable. So study type or population group. And if you do have the data, if you do have individual patient data, then it's best to do that kind of analysis. So you can pool each study with each high level data from detailed granular data on each study. And that's a little bit more complicated, but that will be the most accurate. But let's assume we do not have patient level data here. We just have study level data. So across the study, you can use a regression option or do some kind of subgroup analysis. And again, these are all, even if these are trials, your systematic review of randomized controlled trials is an observational study. It's not a trial. And it is going to be inherent, it is going to be subject to the same biases that any observational study will be. Plus on top of that, that's the overall analysis. On top of that, you're doing these extra analysis, and often you're looking at the data and then deciding, okay, let me do this and let me do that. So they're all post hoc often, you interpret them with caution. They are not strong necessarily. And what you're trying to explain is just explain what is going on rather than be confident in the analysis that you would be with a simple trial. So a regression is just like, some of you may have done the other regression classes. In this case, each study is a data point, and we look at the covariates. So it's like any logistic regression that you're running. So this is what it looks like for BCG with true latitude. So for some reason, someone suggested that let's look at how far the study center is from the equator. So that big circle you see on the left is the study done in Chennai, the Madras WHO study, which is very close to the equator. The Rosenthal study is the extreme right, the small dot close to between 50 and 60, because it was done in the north. So if you plot studies this way, it does seem, and on the y-axis you have the log of the odds ratio. So if it is 0, that suggests that the relative risk is 1. And minus 1.5 suggests that there is a benefit. So it seems that if a study was done close to the equator, it was likely to be negative. And if a study was done farther away from the equator, it was likely to be positive. And how do you explain that, right? So you need to have some knowledge about TB and the disease to interpret this. If you're just running the stats, you can use any variable and produce these kind of graphs, but they have to make sense. So you have to be able to tell the story behind this, which is going on. So there are a few stories that people have spun about this. And again, these are all post hoc, but it seems the one possibility is, of course, that there may be exposure to vitamin D may be different. And maybe that plays a role. The other one is that there could be genetic differences, but I don't think that has played out very well. But it seems that the strain of the mycobacterium that may be present may be slightly different. So that's the other theory that I've heard that may explain this. And this is kind of paradoxical because what this seems to suggest that BCG in India is not effective, and BCG in Canada, I'm to the north, would be effective, and the public health practices are reversed. No one gets BCG here, but in India, everyone gets a BCG vaccine. But this is not the only story, right? So you could look at quality scoring. So in this case, they didn't use the Gerard scale or the risk of bias that we have talked. There is some other quality assessment score in vaccines, which is based on the method of vaccine assignment and follow-up and so on. And they looked at that. So if you look at that quality score, it seems somewhat similar, is that studies of a lower quality are less likely to show an effect, and studies which were high quality seem to show an effect. So again, maybe it's not latitude, maybe it's the quality of the studies, right? And this is where your prior knowledge can help you. And stats will not give you the final answer. This is, you're just fishing for associations, and you're reporting the association. And the association that you're reporting is at a study level. So it's best to just show that these are the possible factors that explain, but you can't really say what is going on. And in the box over there, you can show that the latitude explains maybe 41%, and validity can explain 30%. but there's an overlap. So maybe some of the studies done at a lower latitude are lower in quality, but even if you put them both together, that explains about 66% of the validity. Of the heterogeneity, not the 100%. But this is like I'm using this example because this is a dramatic that it shows 66%. I've done a lot of meta-regression, and most of the times I can explain maybe 10 or 15% of the heterogeneity. It's not very common that one can explain a huge amount like this. What about the rates in the control arm? So those who did not get BCG. So you can use that as well, and looked at that as to whether if the control rate was high or low, if that has an effect. And again, that seems to be the case, that if the control rate events were high, then it seems there is less of an effect, whereas control rate events were low, then it seems to have an effect. So you add that on, you get some more explanation of heterogeneity. Or the other thing with the control rate is you can say, hey, I will not look at control rate as a percentage, but I'll say high and low. And then it shows that if it's high, then there seems to be a benefit. If it's low, then there is less of a benefit. So you can group them into two in this software. So the conclusion in a study like that is that there is a substantial heterogeneity. And the vaccine is more effective, probably, but it's more effective in studies done at a higher latitude, in higher quality studies, and with harder outcomes, or with higher control event rates. So that's the kind of analysis that you want to present, rather than say, hey, BCG vaccine works or BCG vaccine doesn't work. And this actually makes it a little bit richer. You are telling the story, and it makes your analysis and the picture you're explaining far more useful to users, especially when you have different studies and people going around with different conclusions. So dealing with studies, use an exploratory approach to summarize. Some people would say, hey, ignore, use the fixed effects model and remove the outliers. And I'll show you a way to remove outliers, but it's not really the right way to do things. You can use a random effects model and use the Q and I square to decide that. But doing a subgroup or sensitivity analysis is far more useful. With the regression option and random effects meta-regression. And don't just use the option of removing the outliers. Before I go on to publication bias, let me just show you how simple it is to make these graphs. Let's see if I can exit this and just show the software. So there is a review manager software, of course. If any one of you, can you see the review? I hope you can see the review manager software now on my screen.
Yes, we can see it.
Okay. So if anyone of you has played with it, it's a little bit clunky, because what the Cochrane people want you to do is to do a systematic review and not do just a meta-analysis. Not just just put the data and crunch them and produce a forest plot. So it forces you to click on all the title, the abstract. And if you start putting those things in, at the end of it, you get a Cochrane review, the paper, as they say. So, if some of you played around with it, you could include everything here that I'm talking about. But I was, in the interest of time, I did not do that. What you should do is, you go to tables and studies and right click and add studies like that. And then you can keep on adding studies. You need not fill this out, or the high risk of bias. It's what they want is the name of the study if you want to enter the data. And then you go into data analysis outcomes, and then you say, hey, I want to add an outcome, and then you can add outcomes. Let's see here. Yeah, so and then if you click on the outcomes, you can then right click and say add study data. So I've added 3 study data there already, and it starts generating your meta-analysis on the side. So don't look at it while you're adding. But let's say you add study data. I've already added 3 studies data. These are the ones that Atul that we had circulated earlier. and it's very easy. This is just showing.
Swapnil, can I
Yes,
interrupt for a minute? I think
yes.
most of us are not able to see the Revman, so you
Oh,
probably need to stop sharing your screen, open Revman, and then start sharing screen again.
okay. So right now you're not seeing anything.
We are only seeing your slides.
Okay, let me stop sharing and start. Yes. So can you see Revman now?
Yes, perfect. Yeah.
Okay, yeah, sorry. Let me just go back. Uh, so Revman forces you to, if you look on the left, it forces you to, if you start off, it will say, hey, write this, make sure, what is the question that you're doing, what are the studies, and it will make you, once you say, if you go to tables and add study, that's the easiest way to just jump in and start adding studies. These are shortcuts. Ideally, if you're doing a systematic review, you should go through the actual process, and it forces you to do the real process. So it asks you about all the studies that you found, which studies did you include, why did you exclude the studies that you excluded. So it's really pitched towards doing a proper systematic review. In this case, if you just want to enter the data and do a meta-analysis, I'm just showing a shortcut which bypasses all of that. So if you click on tables and studies, you can add studies. In this case, I've added the Amara, Ibrahim. I think I added Ibrahim twice. The Knoll, the Mandelbrot. So these are the studies that we had circulated on the Excel sheet. Again, I have not added anything here. This is blank. Ideally, you should be doing that. You should be doing a risk of bias. What this does is, once you start adding that, with one click, it will make the table, which you include in your systematic review. So this is sort of like, it walks you through the entire process of making tables, of making a systematic review. But if you just want to do the forest plot, I've chosen death here. So you click on the data analysis aspect, add an outcome. So you could add, something else. You could add graft failure, for example, and click on death, and then say add study data. And once you start adding study data, so let me add one more. It doesn't take a long, so you click on this and just say finish. And it shows 0000. That doesn't mean it's zero, because it just doesn't know what is the study data. So you can click on the, and again, I'm just writing the numbers here. So in the ACE group, they had 2. The sample size was 54. The control event sample size was, events were 0. Is that midway? Yeah. And the events were, the total sample size was 69 in that one. Oh, I think in Amara, I put the wrong one. So, so it's easy. You just click on the boxes and you change those numbers. So what you see here is your forest plot on the right, and it's telling you that with these 4 studies, you are getting an effect size which is somewhere here, and you click on these boxes on the type. So this tells you a risk difference rather than relative risk, which is the other option that we talked about. And here you can choose between a fixed effect and a random effect. In this case, because the studies are quite homogeneous, using fixed effect or random effect does not make any difference. This is a funnel plot that I'll come to shortly, which tells you about the publication bias. This part is not that difficult. And this is the weight, which is labeling here, which tells you the weight of the study. And the forest plot itself will show you, you can click on it and it will make you, it can generate a high quality forest plot to be included in your final paper as well. So let me just go back to stop. Go back to a little bit more on publication bias, and then we can come back to the software. So the clicking on the numbers and generating a forest plot is the easiest part of it. The question is, should you be doing it, extracting the data and looking at the data and deciding whether you want to do a meta-analysis or not, and how to do it, how to deal with heterogeneity. Those are the qualitative, the intellectual part of it, which is more fun. To just put in numbers in the software and make a forest plot is very easy. Apart from navigating and understanding how to use RevMan or the other software that you're using, this is the more interesting part about it. And again, I'll come back to the software, but let's talk a little bit more about publication bias. So the problem with publication bias is that small negative studies are less likely to be published. So let's say you do a study, I do a study of a trial of 1,000 patients, and I find some effect, I'm sure JSN or AJKD or even the New England may accept it and it'll get published. On the other hand, I do a single center study of 25 patients and I don't find any effect. It may be hard for me to convince any journal to take it. So then what do? I can, try to get it published somewhere. And these days, of course, you have more journals. There's a Canadian Journal of Kidney Health and Disease. Maybe that will publish. I have to pay $2,000 to them, but maybe they will publish my paper. But otherwise, what happens is that your trainee did the study and they have passed and they have gone into private practice, and it remains unpublished. So it remains in the shelf, in the file drawer, and especially the non-significant papers and the smaller studies don't get published. If it's positive, it's more likely that some journal will be interested. Oh, you're showing that this thing works, that remdesivir, hydroxychloroquine reduces mortality. Oh yes, let's publish it. Whereas if you show hydroxychloroquine doesn't show anything, and it's a small study, people will say, oh, we know that, I'm not interested in publishing your study. So that's the kind of problem that can happen. And how do we find out? And that can bias your meta-analysis. So how can we look at it? So the statistical tool is to do a funnel plot, which can look at graphically look at the effect. Or you can do a cumulative meta-analysis, and I'll show you one way to do that. And there are different tests that can also be done. So the Eggers test gives you a statistic, whether, with a p-value for whether there is publication bias or not. And depending on the software you're using, you may or may not get that number easily. And there is something called as the Duval and Tweedy's trim and fill method, which actually fills in some studies for you. It imputes some studies statistically saying, hey, I want to make the funnel plot symmetric. So it will fill in a few studies and will give you an adjusted estimate as well. So what is a funnel plot? That's the funnel that you may have used in chemistry. So you just turn it around, and that's what we are looking for in the meta-analysis. So for example, here the studies that are on the top of the funnel are the large studies because they have a smaller standard error. And again, the assumption here is that larger studies are giving you the truthful answer. So it's the truthful answer that you want, which is giving you the actual real data. And the smaller studies, because of random variation, the effect sizes in the smaller studies are going to be a little bit scattered. So in this graph, the overall effect size may be, there seems to be a small benefit. The solid line is just where no effect lies. But it seems that the blue dots are scattered fairly symmetrically across. So it doesn't seem like there is any publication bias in this funnel plot. But in some cases, it's far more apparent. So this was a study of haloperidol versus placebo. And you can see that, there is an area where there is nothing. So most of the studies are scattered in the favors haloperidol angle, and there are very few showing placebo. And the large studies are actually somewhere in the middle. So it's the small studies that are showing a benefit, whereas there are no small studies which do not show a benefit. And the largest studies are somewhere in between. So that, even looking at this kind of a funnel plot and a triangle can tell you that there is something that is not, making sense. So you're looking for asymmetry. And again here, so on the top, you can see that there is some asymmetry, whereas on the bottom, it looks like, you have fairly reasonable number of studies scattered around the mean. This is an extreme example. It's not a funnel plot, but it's just an extreme example of publication bias. So this was a systematic review of antidepressant trials, which was published in the New England. So in this, this is the journal version. So there are papers that were published, and the red line is, so the studies that are above the red line, they are positive studies. They show that antidepressants are having a beneficial effect. And the studies that are below the red line, so there are the two black. So there's something for mirtazapine and something for Paxil, for paroxetine. So that those have a couple of negative studies, but otherwise it seems that most of the studies are positive, and it looks like these drugs may work. But the FDA gets raw data, and they get the full data, not what is published in journals. So these Eric Turner, who published this, he actually worked for FDA at that time. So he got, and you can ask FDA for the data. So they got the actual data, which is not the published version. And when they looked at it, it is quite dramatically different. So you can see that with all the data that is not published that FDA got, there are way more negative studies that never made the light of publication. And it seems to suggest that for most drugs, that maybe for a couple of them there may be an effect, but for otherwise, so most antidepressants, maybe the first one, fluoxetine, there are 4 positive studies and 1 negative studies, but for many of them, especially paroxetine and mirtazapine, the studies are negative, and for sertraline, Zoloft, there are way more negative studies than positive studies, which never made the light of day. So this is something that you have to be careful of when you, in this case, of course, a funnel plot may or may not pick it up, but if it shows that there is asymmetry, you have to be very careful and beware of what might be going on.
Can I sort of say now?
Yeah, go ahead.
Now it is possible that with the preprint, if you can take from there also, you should be able to manage somehow or the other, rather than coming to those the studies which you had said for the ECG thing and for reference.
Exactly. So
preprint
So
gives an opportunity now to take a balanced view, even if
so
have any bias. In that case, I think one should also look in for the preprint thing if it is available.
Yeah, absolutely. So
Right.
this is where the literature search aspect comes into play, right? So if you just look at Medline and Embase and the things that we talked about, you may miss all these studies. Now, as a pilot project, during the time of COVID, uh, PubMed has started putting preprints in. So there are some preprints from medRxiv that you will find in PubMed. I don't know how long the pilot will last and whether all the preprints are actually making it in, but it makes a lot of sense. So in terms of search, it's not just it makes a lot of sense to search for preprints. Google Scholar does search preprints. So if you search in Google Scholar, it will show you the preprints. But again, like we mentioned last time, searching in Google Scholar gives you a lot of results. So you have to be careful how you're searching it. But what you could do is you could do a dedicated search in medRxiv or bioRxiv or whichever preprint server you are having. And again, the problem is that there are many preprint servers. Lancet has a SSRN preprint server. medRxiv, of course, is the better known preprint server. So you definitely could search the preprint servers. The other option is that you could actually search the clinical trials registry. So you can go either on the WHO clinical trials registry, or you can go on the clinicaltrials.gov, the NIH registry. and search for trials. And that will show up all the trials that people have said they will do. It will not show up unregistered trials, which these days are uncommon because registration is easy and most people are encouraged to register. And then you can line up the registered trials with the publications. And if there are trials that have been completed but not published, then you can actually go looking for them. Are they being published on a preprint or somewhere, or you can contact the author. So yes, there are many ways to deal with publication bias. I just mentioned the statistical imputing is one option, but that doesn't distinguish the real, the real studies which are there. It's just the stats makes up some decision. So if you can actually find studies and do a search which is more in depth, that can solve this problem. And there's less excuse now for people to not publish, right? With preprints, you could put the paper into the preprint, but the preprint model, which I would strongly support, hasn't yet completely been accepted by everyone. So not all people are putting their papers into preprint. For example, there is a Dutch study on masks. It's on trial. It's a trial on masks with many thousand patients, whether masks are effective in COVID transmission or not. I'm told that it has been rejected by NEJM, JAMA, and the big journals, Lancet. Now, it would be easy for them to put it on a preprint.
Can I say?
Yeah.
Most of the journals, they don't sort of appreciate preprints. They don't allow. That is the reason.
Yeah, and that's exactly, that's a different topic. We have published on that, and New England has changed their policy during COVID, and they have accepted that they will take preprints. Lancet has its own preprint server, and they will take it. In JAMA is very strongly opposed to preprints. All the JAMA journals say if you have already done a preprint, it's prior publication. We are not interested. In nephrology, JSN previously had a policy of not accepting, but they have changed with the current editor-in-chief, Josephine Briggs, who used to work at NIH before. So they accept preprints. CJSN did not have a policy until we asked them a couple of years ago, and they said they will accept it. So in nephrology, and I can send you our paper where we asked individual journals for their policy. All journals are accepting preprints except for AJKD and kidney medicine. So the National Kidney Foundation journals, AJKD and kidney medicine, they will not accept preprints, but Kidney International will, JSN will, KI reports will, and JSN, CJSN will. So the culture is changing, and hopefully it will move towards a point where this will be the standard that you all publish, put your data into a preprint, which is very easy. I have put papers into preprint. All you do is upload your Word document and, a few other data points, and you're done. And it's available for people to look at. And it is time-stamped, right? So if there is something, you cannot get scooped. So someone else cannot say, oh, I was the first one to discover CRISPR. It's because if you have put it on the preprint server, then you're the first one. With that discovery. Again, though it is not peer reviewed, etc., but for our sake, for our meta-analysis perspective, all you want is the data. And if it is on a preprint, because some journal is not interested in your negative study, that is definitely a really good option. From the editor's perspective, people look at this, and the reason this is important is why are people still doing studies when the answer is available? And for that, let me just show something called as a cumulative meta-analysis. So in this case, the animation is already running. So this is a streptokinase in MI. So you can see that in the forest plot there on the left, there are a bunch of studies, and overall there seems to be a benefit. And you may say, hey, the first study was done in 1959. And the last study was done in 1988. So it took 30 years for us. There were some positive studies and there were some negative studies. And it took, a little while for us to figure out that there is truly a benefit. But that's really not the case. So if you run a cumulative meta-analysis, and in a cumulative meta-analysis, what you do is you add the studies as they are getting published. So on top you see just the Fletcher trial, and then when the DEVAR trial is done, you add DEVAR, and then when the European one is done, you add the European one, and when European 2 is done, you add European 2. And wait, oh sorry, when you add European 2, you already see that there is a benefit. But then the next study by Heikenheim was negative. So again, it pulls the estimate towards 1, but then you add the Italian, the Australian one, the Frankfurt 2, and suddenly now the benefit, at somewhere in 1973, it seems that, the p-value is 0.0071, and the z-score is so high that it seems clear that there is a benefit. But what is going on? People keep doing STAT trials. So in 1973, it was clear that there was a benefit, but people keep doing trial after trial, and you look at the GC1, and the GC1 is the one which is held up in 1985 as the big trial, which showed that streptokinase is effective. But really, we knew way before then. So that was 1986. So I would say if people had done a cumulative meta-analysis 13 years prior to that, you would have seen that streptokinase was effective. But we kept on doing trials, and even after JC, there were 2 more years of trials being done, and they really they shifted the curve a little bit. But throughout this period, it was extremely clear that streptokinase was effective compared to placebo. So this is one way of getting to the truth easier, and this is something that is encouraged now. If you publish a trial in Lancet, for example, they will say, hey, what are the previous trials done so far, and they encourage you, in fact, to do a meta-analysis as well, to put the results into perspective. And sometimes the meta-analysis can tell you, hey, stop, do not do any more trials, we know the answer here. And that's also very useful, and that's sort of what this kind of analysis does. But it could be the other way around as well. This is a meta-analysis of which goes the other way, where you can see that initially some studies were showing that there might be a benefit, but somewhere along 2001 it shows that there is no longer a benefit. But people keep doing trials hoping that they will find some kind of an effect. So it was very clear in 2001, 2002 that there was no effect. But for 10 more years, people kept studying this question. So you're exposing patients, you're spending a lot of money doing trials where the point estimates, the confidence intervals are so tight that it would be very, very unlikely that a signal is being missed. So, and again, these are things I'm speaking from a perspective of someone who does meta-analysis, to say that you should be doing meta-analysis as the trials are coming out, rather than wait 10 years after that to find out if something works or something doesn't work.
No, at this point,
Yeah.
can I say something? Now, it is likely
Yeah.
that they might have done streptokinase vis-a-vis urokinase vis-a-vis something else. The question at the start might be different, and that is why it's been added, and the race may be different.
Yeah, exactly. So I'm taking a simplistic. You're absolutely right. I'm taking a simplistic point of view here, and sometimes it may be, in fact, that say there were there could have been publication bias, that negative studies were missing, and you often need a large trial to convince people that something should be done or something should not be done. So in contrast, nephropathy, I've been convinced since 10 years that mucomist doesn't work, N-acetylcysteine, but people kept doing trials after trials. There was a ACT trial from Brazil of 2,200 patients which showed it doesn't work. This was published in 2013. Still, PRESERVE was going on, and the it took PRESERVE with 5,000 patients to show that there is absolutely no effect for people to be convinced that N-acetylcysteine doesn't work. So sometimes it does take a large trial to convince people that something does work or doesn't work. It's not that a small meta-analysis is enough. People will say, oh, I don't believe in meta-analysis. I'm just showing that sometimes it is possible for the scientific community to get an answer. earlier. And we are actually seeing this happen right now with remdesivir. There are some trials that are negative and some trials that are positive, and there's, I'm not going to go into that and say which one do I believe, but there is there is some interesting discussion going on there where meta-analysis may be helpful. So before you go on and say, hey, I've got the software, I've got RevMan, and let's do this, you should stop and think, um, should you be actually doing meta-analysis? You can do it. The software allows you to do it. Does it mean that you should be doing it? So stop and look at the data and think, maybe a qualitative synthesis is enough, or maybe there is too much heterogeneity. So you should not proceed. But if you can, it's okay to go ahead. But I would recommend that you should make tables and you should study them before proceeding with the meta-analysis. You should plan for heterogeneity and clinical factors to explain even before you look at the tables. I would strongly encourage you to look at the tables that you're making before putting data into the forest plot, and that's what we did with RevMan today. But that's not what you should be doing. You should be looking at the individual papers. You should be reading them. You should be looking at all the factors that are important before just jumping into doing the meta-analysis. And try to identify a few factors that are different, just for your sake. How are these studies different than each other? Is the comparator calcium channel plus blocker, or is it a thiazide diuretic, or is it a placebo? And plan for doing some subgroup analysis. Is the follow-up 6 months versus 5 years? Maybe that matters. Maybe at 6 months there seems to be a benefit, but at 5 years the benefit goes away, which is still useful information to show that in the long term there may not be a benefit, but in the short term there might be a benefit. And you can use subgroup analysis and meta-regression to explore, and don't forget about publication bias. So before I end, let me just show you another software. I'll stop screen sharing, and I'll try to open another one before I show you so that you can see it. So the other software that I would recommend you can play around with and try is called OpenMeta. It's also free. And the reason I like it is that it allows you to do some more fun analysis. So I'm just opening it, and then I will share my screen again to make sure everyone can see that. So can people see this Open Meta-analyst screen?
Yes, you're good to go.
Okay. Okay. So you can either say create a new project where you can enter data. I'm just opening, I put in the BCG data that I showed you. Oh, let me try again. Okay. I hope you're seeing the Open Meta-analyst now.
Yes, yeah.
Yeah. So here it is very easy. So this is, it sort of looks like Excel even. So you can import data. If you click on plus, it will ask you what you want to do. And you can even import data from Excel. So if you enter data into Excel, you can save it as a CSV file, which is very close to Excel, comma supported values, and you can import that file into this. So this is it's easier in some respects. I'm not saying you should use it because it's easier. It's sort of like SPSS where point and click, but RevMan is more rigorous in that it makes you run through the actual checklist and put in all the stuff before you jump in and just do the analysis. So in here, you can see these are the study names, and it's, all you have to do is type in, I'll say Atul did one study, so I'm adding that here. And in 2020, and these are the events in group A is, let's say, I'm making up numbers, right? So 34, excuse me. So there were 1,000 patients in one, and there were 15 events with 1,200 patients. Sorry, done. That's it. And then I click on this meta-analysis, and it gives me a bunch of options. So, and these are the options that, this is why I would say, this has some features. So after you do the initial analysis in RevMan, you can run the analysis here to do the other stuff that you may want to do. So here, the default is random effects with the Darsimonian layered effect, but you can choose, you can say you want to use the fixed effect, and you click OK, and this is what you get. So again, the weights, as you can see, I just added, Atul study here, but the Madras study gets a weight of 41%, and the Stein study gets 22%, and this is the forest plot that you see. The picture is not as nice as RevMan, but you can right click and save the image as wherever, or you can even edit the plot and make some changes. But let's go back and try other options. So instead of using the fixed effect, you can use the random effect, and you get a slightly different answer here, as we discussed. So this is the random effect answer, which is different than the fixed effect. And if you scroll up, you can see the weights are way different. So the Madras study has a weight of 8% instead of 42%, which was in the fixed effect model. But this is not done. We are not done. So this is just one way of doing a random effect. Excuse me. There are other ways. So there's a, there's a hedges option. There is a Siddick-Jonkman option. There is a Bayes and restricted maximum likelihood option. So there are other options that it gives you, which you can use. And in some cases, you may want to use those other options. So that's the one additional advantage that you have with OpenMeta. The other option is, this is the cumulative meta-analysis. So just one click, you can choose whether you want to use random effects or fixed effects. And this is giving you a cumulative meta-analysis. So so you can see here that you add Aronson, the estimate is 0.39. Then you add Ferguson, it becomes 0.249. You add Rosenthal, which was a very small study, so the point estimate doesn't change. It remains 0.249. You add Hart, it becomes 0.236. You add Fremont, it becomes 0.333. You add Stein, it becomes 0.5, and so on. And once you add, Madras, it becomes 0.506. So in this case, of course, the cumulative meta-analysis wasn't very useful in BCG. But this is one way of doing a cumulative analysis, just a simple click, and it gives you the answers. The other ones is you can do a subgroup analysis. So for doing a subgroup analysis, you need a subgroup. So the way you add a subgroup is you click on top for analysis, and you say add dataset and add covariate. And you make up a covariate. So let me just make up a fake covariate. We talked about adults, so I'll say adult, and I'll say it's a factor, so meaning it's a qualitative thing, and I'm just making up things here. So I'm saying Aronson was adult, and maybe Ferguson was children. Okay, so we had, and I'll just fill those things out. Okay, and then you say, okay, I want to do a subgroup analysis. Let's say adult, and with the random effects. Yeah, and it gives me two subgroups. So these are the ones where I said adult was 1, and this is where I said the adult was 2. So it gives me a forest plot and a summary effect for group 1 and a summary effect for group 2. It's as easy as that. Just add one column and you're done. And the same thing you can do for a quantitative. So in this case, I put in some latitude numbers. And again, these are all fake numbers, right? This is not the actual analysis that I showed you in the slide set. In this case, I said Madras is exactly on the equator because I know it has no effect. And I put some of the effective studies far up there. So if you click on this, which is the meta-regression, and I said, hey, let's look at latitude with a random effect model. Um, this is sort of the plot that you get. This is similar to the graph I showed you. So it shows that studies which were closer to the equator did not show any effect, whereas studies that are far away from the equator did show an effect. And again, you just code the covariate as being continuous, and you can get that kind of an analysis. I put a fake study quality. You can do the same thing with that. And the last thing is leave one out. So we talked about excluding outliers, which is not something you should be doing. But this is to look at the data and again, the purpose here is to see is one study pulling your effect size somewhere strange, and then you examine that study a little bit closely. So this is the if you leave one study out meta-analysis. So we did random effect. Let me do fixed to get a more impressive. Yeah. So in this case, what is happening is that if you leave out this, the top row is Aronson. So if you leave out Aronson, it doesn't seem to make much of a difference. If you leave out Ferguson, it doesn't do much. If you leave out Rosenthal, it doesn't do much. If you leave out Hart, it seems that suddenly BCG is worse. If you leave out Stein, BCG is way better. So those kind of things tell you, and again, these are not real data, but if you see something like that, then you should look closely at those studies, saying, hey, what are those studies doing? Are they very different? Maybe, and again, you need a really, really good rationale for you need a really good rationale for you to use one option or the other. Throwing out studies is never a good option. You need any stats person or epidemiologist will tell you that excluding studies is excluding data points is a bad option, and you should not be doing that. So you better have good reason to exclude something. But you can show your work. You can show that this is the main analysis, but it looks like these two studies had a strong influence on the results. And if we exclude them, this is what you get. So rather than excluding them and showing that result, it's just to be open and transparent and show that, this is the overall effect size, but these two studies had a large effect. And then you can examine those studies. And let's say one study was really poor quality and, the randomization was messy and what have you. Then you can be justified in saying, hey, this study is pulling the data and making us provide false conclusions. So excluding this study really makes a difference. And that's the analysis you should be considering. So again, we have 25 minutes. So I would like to thank Dr. Rajapurkar and Atul and the organizers for doing this. And I'm as always, I give a pitch to using Twitter and our journal club. So next week, not coming Tuesday, the week after that, we will be discussing the Fidelio trial, the finerenone on CKD on NFGC. There'll be an Indian chat as well on Wednesday night at 9 p.m. And so if you are interested, you can join in and discuss this study. So thank you, and I will be happy to, Atul and I will be happy to answer any questions. Yeah, that is in the chat box. There is someone talking about preprints, and it's exactly right. The topic of preprints is a little bit controversial. It's not as clean and simple. I can make up a fake paper with Atul's and my name and put it up on a preprint server, and no one will be wiser. The trial may not have been done, I can make up fake numbers and put it up, and no one will pick it up. So if you're doing a meta-analysis and you just say, "Oh, I found a preprint, I'll use it," be careful. So it's not as clear as that. It may be a useful source for finding trials that are done, but are not yet published, and you should make it clear that this is non-peer reviewed stuff. It's not. It doesn't mean that peer reviewed papers. It's a different topic completely. It doesn't mean that peer reviewed papers are totally legitimate. We have seen that some papers have been retracted even from New England and Lancet recently. But it's just something to be aware of, that you can't just accept preprints.
No. So I'm from ICMR. I am Dr. Trupti Khanna. Regarding the preprints, it is only giving you an avenue. If you are interested, you can always speak to the PI concerned and confirm the data.
Exactly.
Ask for. So it is just to be aware of what all is possible before you do a systematic review or a meta-analysis. That was the only.
Yeah, absolutely. I'm with you on that. I'm a huge proponent of preprints. I'm trying to put my papers onto preprints before journals take them. But you're right that some journals still have a myopic view. It is changing, and I hope it will change even more faster, that they accept preprints. When one of my colleagues, I was telling we should put this on a preprint, he said, "What is a preprint? Don't put it on a preprint." So I had to explain it to him that it's legitimate and it's okay to do that. But then we could not submit our paper to JAMA Cardiology, which is where we wanted to submit it. So it's going to another journal. So there is still a pros and cons of preprints. We can talk for hours on this topic of preprints, but I agree with you that it's a useful source for unpublished information. The other thing is also clinical trials. So clinicaltrials.gov, the NIH registry, it also allows for trial data to be uploaded before they're published. So for example, for the NIH study on remdesivir, there was an initial interim data which was published in New England, and the final data, the 28-day mortality, had not been published for 6 months. But it turns out that they did put it out on the clinical trials registry. So it was available like 2 weeks before it came out in an EGM, because they had the data, right? And everyone was asking for it. So I think they quietly uploaded the data to clinical trials while the paper was accepted at New England, and it was being formatted and peer reviewed and proofs and what have you. So that's clinicaltrials.gov could also be a source for finding trial data, not just for trials that are ongoing or completed, but actually finding the data as well. And again, that is non-peer reviewed. So sort of like preprints, you have to be quite careful accepting that, but it does exist.
Any other questions? Because I think this is a great opportunity to interact with Dr. Hiremath, who is a well-known expert in systematic reviews. And I honestly feel that we have lots of opportunity to do systematic reviews from our country, because we know that there are challenges in doing clinical research in our country. Systematic reviews has much less challenges, except that we need to have good resources, a good library, that's all, and understanding of the process. So what we would like to have is many more systematic reviews being published from our country. So I think take this opportunity and ask questions and maybe start doing some reviews.
Yeah, and as we sort of discussed last time as well, is that whenever you have any research question, you should start off with a systematic review. So if you're doing a thesis project or whatever, before saying, "Hey, I want to study," I'll make up something, fish oil in lupus, rather than just doing a case control study or a observational study, do a systematic review. Maybe other people have published it, and in the first, and you can crunch out if you have time. and you spent your evenings and nights in front of a computer and you're happy to do that, which we are all of us doing right now with Zoom anyway, you can finish a systematic review in a matter of weeks or months. So, by the time it gets your project to be approved by a supervisor, you could get a systematic review completed. So whether your project takes off or not, you could have a paper and a project, and then you do the actual project, and then you could you could do a cumulative meta-analysis, adding your paper to the other papers you had done before. So all sorts of things are possible, and you may find some new questions, right? You may find out, oh, there are all these papers on fish oil and lupus that I did not know of, but they seem to work in class 5 and not in class, I'm making up stuff, in class 2. And then you can say, okay, after finding this, I can I'll do the study in class 5 lupus instead of all patients with lupus. So it can actually change what you're doing.
Dr. Swapnil, I am Tripti Khanna again. I need to thank you for very lucid and a very wonderful lecture. I was looking forward to it, and I'm really honored to be a part of this. But the one that you are going to say about the meeting, which is going to take place about the diabetic kidney disease kidney, I'd like to be a part of that as well.
Yeah. Sure. So if you email me, I'll send you the details about how to join. It's open. It's completely open. So all you need is a Twitter account. But I can email you the details. So just send me an email.
Thank you, sir.
And
maybe Dr. Rajapurkar can help.
yes. And there are many people in the Indian community on Twitter who can also help.
Sure, I'll give you Swapnil's email.
Thank you, sir.
You're welcome. There was another question in the chat box from Indu Rao about a publication bias. If the number of studies are included are less than 10. You're absolutely right. If I have 3 or 4 studies, you don't have enough of a sample size to assess for publication bias. You need a large number. And the same applies to doing subgroup analysis. It applies to doing meta-regression. And it applies to publication bias, because you need enough samples. So the more samples you have, the more robust your analysis is going to be. And remember here, the sample is not the number of patients that you have. It's the number of studies. So even if you have 3 studies with 40,000 patients, your sample size is not 40,000. Your sample size is 3. So then with 3 studies, you cannot, despite having 40,000 patients, you cannot really assess properly for publication bias or for doing any kind of subgroups, because if you do a subgroup, you've got 1 study and 2 studies. So it's really not any kind of meta-analysis you're doing or to do a meta-regression. So for any of those issues, you do need to have a large number of, even if they're small trials, that's fine. You need to have a large number of trials, and a rough rule of thumb is indeed 10 or more is a good number to do these analysis properly.
Can I ask you a question, Swapnil? What is your take on the Eggers test for publication bias? How good is it?
Yeah, so many of these tests are again, the software gives these numbers to you, and I'm honestly not sure how powerful they are. For the Eggers test, for example, 0.1 instead of 0.05, people say use 0.1 to say that there is significant publication bias. And what that tells you is that if the p-value is 0.08, then there is significant publication bias. But there are times when you look at the funnel plot and there seems to be publication bias, and the Eggers test may be 0.11 or 0.12 or 0.15, and it's often because of the same issue, is that you don't have enough samples. Perhaps. So then people are saying, hey, maybe 0.1 is not good enough. Maybe you should use 0.2. And it's sort of like, if you remember the story, I don't know whether it's true or not. The P 0.05 that we all use was Ronald Fisher. So Fisher was asked, the story goes that, there was a statistical meeting and people were talking about how do we say one group is different than the other, and everyone looked towards Fisher. So Fisher was like, like Dr. Acharya or Dr. Chug or someone in that time. So he was sitting there, and they all looked at him, and he said, "Oh, if it is 1 in 20, so P of 0.5, I think we should be fairly confident." And that's how P05, he just made it up on the spot. And that's how P05 became our standard. And the other story, which is more fun, is that on his deathbed, apparently, as he was dying, he said, "I did not mean 1 in 20. I meant 1 in 90 or something like that. It should not be P of 0.5. It should be P of 0.1." So it is completely arbitrary. These 0.5 and whatever else we do is completely arbitrary. So the same thing, like Egger's test, it's even worse, right? It's we are extrapolating from the trials to publication bias. So it definitely shouldn't be 0.5. I have often used 0.1 because journals force you to choose some number. But you're right, maybe it is 0.2. And the visual examination of the forest of the funnel plot, that depends on your and my subjective interpretation of that funnel. It's not completely objective as well. So these things are it's best to state this is what you found, rather than say that publication bias was significant or publication bias was not significant. It's better to say, hey, the Eggers test showed that the p-value for the slope was 0.18 or 1.5 or what have you. If it is very, very low, the p-value is very low, then it becomes a little bit more clear.
Okay, so if there are no further questions, then I'll hand it over to Dr. Rajakurkar.
Well, thank you very much. I will also add a little bit of mine for saying about preprint and the peer-reviewed published. So if you're dishonest and you're submitted dishonest data, I don't think peer reviewers can actually pick up a cooked data. So I think, as you rightly said, that preprints are important. And you start with an assumption of good faith in whatever is put up in print, unless it looks too far out of the usual, is how I would look at it when I look at these things. Also, you can ask a common sense question to yourself, does it appear plausible or not? Now, people have said that common sense is not a very common thing, but still, one could look at it that way. Anyway, Swapnil, thank you very much. And I seriously hope that at least a few of our participants bother you beyond this workshop too. I'm grateful that you agreed to our invitation and did such a fantastic job on making a really difficult subject conceptually understandable. Thank you very much.
Thank you. And like we discussed last time, my email is available.
Yes.
Feel free to contact me. Atul and I would be happy to help anyone and walk through you doing a meta-analysis and systematic review. I like you, I really hope some of you end up doing one. And thanks for having me.
Thank you very much. I hope that most of you join me tomorrow morning for the last session of this workshop on randomized controlled trial crossover design. Tomorrow morning, 8:40 a.m. onwards, you can start joining. 9 o'clock we'll start. Thank you very much. And Swapnil, have a nice festive season. Thank you.
Thank you. Thank you. You too.
Thank you.